Hi, I'm Ellen Blair, co-founder and director of the Catherine Elizabeth Blair Memorial Foundation. Today, I'm going to introduce you to Dr. Kelly Goldsmith. Dr. Goldsmith is a professor of pediatrics at the Emory University School of Medicine and a pediatric oncologist who specializes in childhood solid tumors at the Aflac Cancer Center and Children's Healthcare of Atlanta. She serves as co-leader of the Discovery and Developmental Therapeutics Research Program at Winship Cancer Institute of Emory University and as the director of the Neuroblastoma MIBG Therapy Program. Dr. Goldsmith is one of the primary researchers for an exciting ongoing neuroblastoma research study that we have recently funded. Our foundation helped fund a research study led by Dr. Goldsmith in 2021, and we are so pleased to be able to contribute to her work again. Welcome, Kelly, and thank you for taking the time to talk to our supporters.
Thank you so much, Ellen, for having me and for supporting my research and pediatric cancer research altogether.
Well, we're so glad to do that. The title of the research study is a Children's Oncology Group Phase 3 study of Dinutuximab added to intensive multimodal therapy for children with newly diagnosed high-risk neuroblastoma. That's a mouthful. Can you tell us a little bit about the study?
Sure. I'll probably start by giving a little bit of background. Neuroblastoma is the most common extracranial solid tumor of childhood, meaning it's not a brain tumor. And the cure rates for patients with high-risk neuroblastoma really greatly improved over the past 15 years when we started treating patients with an antibody therapy called dinutuximab. And later on, we found out that when we combined dinutuximab with chemotherapy, standard chemotherapy agents that our patients get, that even patients with aggressive relapsed neuroblastoma had pretty amazing responses, meaning that their tumors were killed off by this combination therapy. And so that really led us as a neuroblastoma community to want to investigate whether we could include dinutuximab upfront into standard of care induction chemotherapy for newly diagnosed patients with high-risk neuroblastoma so that we can cure those patients and avoid them becoming relapsed in the first place. And so pilot studies of this combination of dinutuximab and chemotherapy in the first part of high-risk neuroblastoma therapy really demonstrated it was very safe. It was tolerable by patients, and it had some really good initial signs of anti-tumor activity. But it was a small pilot study, really looking at the safety profile before giving it to a larger number of patients to see if we could have an effect in improving survival and cure rates of our patients with newly diagnosed high-risk neuroblastoma. So now this trial, ANBL 2131, is taking this chemotherapy combination, so standard chemotherapy, and giving dinutuximab with each cycle of chemotherapy in induction. And then they're also randomizing patients to receive just the standard chemotherapy in induction and seeing if we can improve the cure rates of patients with high-risk neuroblastoma. Importantly, on this trial, along with trying to improve that standard therapy regimen to improve cure rates, we're also collecting tumor specimens and blood specimens of patients throughout the trial to really understand the biology behind why patients respond or why patients are resistant. And this is a really important aspect of any clinical trial, especially a phase 3 clinical trial, because you're using larger number of patients to really understand what we call biomarkers of response. And those biomarkers are going to help us devise new therapies for those patients who don't respond, and also identify those patients who are most likely to benefit from that combination chemotherapy so that we can narrow it down to improve those who don't respond, but then to continue to improve the cure rates of those that do. And so that's what this trial is all about.
Wow, it's very exciting. Um, and I saw as part of the trial also some of the patients who don't originally get the combination
Mhm.
could get it later if it seems
Absolutely.
like that would be what they needed.
So I agree. I didn't bring that up because it wasn't the main purpose of the trial, but what's so exciting about this phase 3 trial is often on what we call a randomized phase 3 trial, you get patients randomized to receive just the standard induction therapy, which has cure rates, but then the experimental arm is the arm with the dinutuximab and induction. But this trial is designed really beautifully to evaluate patients at the end of induction, so the end of 6 cycles of upfront chemotherapy with or without dinutuximab. And for those patients who don't receive the experimental arm or the dinutuximab in induction, for the patients who don't respond to the standard therapy, they get the opportunity to kind of take an extended induction that incorporates dinutuximab with other chemotherapy agents. So this is the first time that's good to be on either arm of the trial, but the trial is designed to still answer that primary question. Can we give dinutuximab an induction? Does it improve response rates overall? And so, we'll also learn about those patients who are what we call refractory to therapy, so they don't respond to standard, just plain old chemotherapy, and whether those patients benefit from adding dinutuximab in an extended induction phase of therapy before they go on to receive all the other phases of high-risk therapy. So thank you for bringing that up.
Thank you. Someone recently asked me to explain to them what is a phase 3 trial, and I would like for you to help us understand, because in the past we have never had the opportunity to fund a phase 3 trial.
Yeah, absolutely. It is complicated, and you don't know it unless you're actually in the weeds, putting a patient on it or studying it. So absolutely, let me describe. So when you have a drug that you want to test in any patient, not just a pediatric patient, you need to go through a stepwise process to ensure it's safe and reasonable to use, as well as effective to use in bigger numbers of patients. So that first step and that first phase trial is called a phase 1 trial. So a phase 1 trial is really evaluating a small number of patients, and it's a safety trial. Is the drug safe? Can we ramp up the dose in different cohorts of patients to see if we can get a really good dose in the patient while minimizing those side effects and also learning about the side effects of that drug? We hope to see a response, and that's what I tell my patients on a phase 1 trial, but that's not the primary purpose of that trial. You're really trying to escalate that dose while documenting the toxicities, but not getting too toxic of a dose to those patients. And for pediatric patients, it's really interesting. They tolerate more therapy than an adult patient that has comorbid conditions. So often when we run a phase 1 trial in pediatric patients, we start at a much higher dose than the adult patients do. A phase 2 dose then takes that dose that you found, which is what we call a recommended phase 2 dose, that top dose that worked. And we study still a small number of patients, and it's really looking at the efficacy of the drug in that small number of patients, while at the same time collecting data to understand the toxicity profile in the acute and maybe a little bit more long-term setting. But at the same time, you're just looking at responses. Does the tumor respond at all? You're not really capturing long-term survival, because oftentimes phase 2 trials are run with patients with relapsed disease or refractory disease, not newly diagnosed patients. So that's called phase 2 trials, your efficacy trial. So phase 1 is toxicity and safety, phase 2 is efficacy. Then you're like, okay, we're seeing tumors respond. We're really excited about this drug. We've got the dose that works and we know the toxicity profile. So the next step is to take that and move that drug into usually newly diagnosed patients, and in the setting of what we call a phase 3 trial. So the phase 3 trial is really taking and fully understanding the response rates of that drug, usually when it's added into the standard of care backbone for the patients with that disease. For example, this is a phase 3 trial that's taking the standard treatment regimen for newly diagnosed patients with high-risk neuroblastoma and adding one thing. They're adding dinutuximab into the second, third, fourth, fifth cycle of induction compared to just your standard therapy, which is our best therapy to date, right? And we don't know if it's going to have an improved response rate or is it going to have more side effects, but we know the side effects profile seems to be very well tolerated. But we don't know that in newly diagnosed patients who sometimes present when they're a little bit sicker because they're sick from their disease until you get therapy started. So a phase 3 trial is really the trial that you take forward to get FDA approval for a drug for that indication, for that tumor type, and for how it's being given in that trial. Does that help explain that? So it's really the pinnacle big trial. You're using big numbers of patients to statistically show that this arm with the dinutuximab is better than this arm, which is your standard of care.
Right.
Yeah.
Thank you. Yes, that helps a lot.
Absolutely.
I'm going to change course a little bit. I want to talk about what's been happening with funding cuts from the federal government, especially with childhood cancer research. So could you tell us from your perspective how the cuts might affect your work and childhood cancer research in general?
Yeah, this is definitely a concern for all of us, Ellen, especially as cancer researchers and as pediatric oncologists who treat our patients. And as you may know, 90% of pediatric patients are treated on clinical trials. Because it's a rare disease, we need to take every patient and treat them to the best of our ability, but also learn from them so that we can continue to improve cure rates with the new standard of care, which is part of these clinical trials. So before this administration, less than 4% of NIH funding for cancer research was goes to support pediatric cancer research. That's before all of these budget cuts that are just now coming through. And that includes both laboratory researchers who are making those novel discoveries to drive novel therapeutics, as well as clinical researchers who are making those new therapeutics come to life and translating them into clinical trials for our pediatric patients. And as you may or may not know, the National Cancer Institute is one of the primary funders for our main organization that runs the clinical trials for pediatric cancer research, being the Children's Oncology Group, which I am a member of. So it is a concern. The current changes to indirect funding costs, as well as to terminations of grants or pauses in grant funding as they're trying to understand where to move forward with policies and procedures and funding, have already impacted us as a pediatric cancer community. For example, my NIH funded grant was not put on pause, but I put in my progress report, and I'm not guaranteed to get the next 4 years of funding. And disparities is in the title of my grant. I'm very hopeful because I will say the people at NIH are incredibly helpful and have tried to help us navigate these new waters. But at the same time, it makes us all take a step back and pause to understand how can we continue to do what we're doing to not just drive new therapies and new laboratory investigations and new clinical trials, but also to foster the young learners who are at this moment walking away. Graduate students are not having an opportunity to go into laboratories of people because the schools cutting down how many graduate students they take because they know there's not going to be as many labs to put those graduate students, meaning your PhD students, your MD, PhD students to go into. So these could have not just impacts right now, but into the long-term future. So I'm very hopeful that we can try to come to terms with this. And I'm actually going to Capitol Hill this week to try to implore our representatives and senators. And I highly recommend that anyone who is able to do that reach out, because the more voices they hear, hopefully they'll understand the dire straits that they're really putting the scientific community in. In terms of moving forward, I think that the best we can do is advocate while we're trying to navigate these new waters and try to continue. I will say that as pediatric cancer researchers, we've all discussed and we're going to continue to go. We're not going to stop what we're doing. We're just going to try to find new avenues, new ways of saying it that will help get our funding from the federal government, but new opportunities to try to figure out novel and thoughtful ways to both fund our scientific approaches as well as get the funding from the federal sources. So it is concerning, but I'm always hopeful. And I think it just needs a lot of advocacy.
Yeah. Well, we will try. We will all try to work on that.
Yeah.
Okay, one last quick question. How can our supporters feel like they are making an impact, even if they are only able to donate a small amount?
That is a great question. Given the lack of federal funding as a whole for cancer research throughout the decades, not just now, I do believe that pediatric cancer researchers are really good at working with private foundations such as yours to keep science moving forward. And so we're incredibly, incredibly grateful. It's not common for only one funding source to support a clinical trial, and there's no hierarchy of acknowledgments of anyone who supports, no matter how big or how small that donation is, that moves it moves the line in allowing us to continue that research, I guess you could say. Therefore, every dollar counts. And really, it's the dollars you don't put in that will prevent us from being able to move forward because the federal government is keeping our hands tied in so many different directions. I do worry about you all and having to bear the burden of these current waters. But at the same time, whatever we can do to work with you to help get the message out that the support is incredibly thoughtful, and we are so very grateful and so incredibly lucky to have organizations such as yours to support us in any way that you're able. And we're here to get the voice out, get the word out, and continue to move pediatric cancer research forward. And it's really with organizations such as yours that are really going to help us do that in this current administration and situation that we are in. And we are incredibly thankful.
Thank you. Kelly, thank you so much for spending some time with us today and for talking to our supporters. And I hope we'll be seeing you soon.
Absolutely. I really look forward to it. And thank you once again for all of your support and all of your.
Thank you so much.
Absolutely.